Hi, and welcome to our Accreta Awareness Month Accreta Expert Series live stream. Thanks so much for joining us today. We're going to give our community a few minutes to join us. We really look forward to this live conversation, Q&A, time to be in community with one another and to learn. So thanks for joining us again. Would you, while you join, pop in the comments where you're joining us from, because we'd love to see where our community members are joining us from across the country and across the globe. Love to hear what you're looking for out of today's conversation, where you're at in your journey, and we just thank you for spending some time with us. Thanks again, and welcome to our Accreta Awareness Month Accreta Expert Series live stream. We're so glad to have you here joining us today. We've got Mariah from Denver, Jackie from England. Pop in the chat where you're joining us from. We'd love to know who's with us here in community today and where you're at in your journey, what you're looking to learn from today's time. Thanks so much. I think we've given some time for our community to join us. I see Kate from Colorado, Christine from Northern Ireland. Great to have you all with us today. Please keep communicating in the chat with one another while we join for this incredible opportunity to learn from an expert in the Accreta field. A couple of experts, that is. We're, as you know, in the final week of another meaningful Accreta Awareness Month campaign. And I'm going to go ahead and bring up the folks we have joining us today.
Accreta survivor based here in Northern California and co-founder of National Accreta Foundation.
Yes, my name's Jory. I'm an Accreta survivor from Columbus, Ohio, and I'm a board member for the National Accreta Foundation. Proud to bring this live stream to you today. Thanks for your support and participation. You know, we've spent this month spreading awareness about placenta accreta spectrum, engaging with our partners at PAS Squared by presenting at their or being part of their annual meeting, generated blood donations as a community, gathered stories, and so much more. And of course, soon we'll be crowning our 2023 Accreta Awareness Champion to recognize our top fundraiser. But there's still time to make a fundraising push if you want to see yourself up on the top of that leaderboard. So I would encourage you, I have some of the swag here, shameless plug for our cute keychains. Our October is Accreta Awareness Month keychains that you can get with a modest donation to support our mission, as well as some gear that you can earn, including this lovely sweatshirt and this awesome National Accreta Foundation hat. And we really believe in spreading awareness in many ways, including through our branded gear that also I know gives me a sense of empowerment and community and connection. So really hoping that you can help us meet our fundraising goal. And of course, there'll be more opportunities coming soon to give back, from engaging with other patients and survivors in our support groups, of course, to participating in Giving Tuesday next month, to scheduling your next blood donation in January when we kick off National Blood Donor Month. So always stay tuned, because we always have calls to action for everyone. And I just like to set the tone when we have these live streams that we understand that often topics can come up during our live streams that may be sensitive or triggering, depending on where you're at in your journey. So we just always encourage you to engage respectfully and compassionately, recognize that everyone is at a different stage in their journey. We're here to learn and be in community together. And so please make this your space, share your questions, your comments, your reaction. And with that, I'm pleased to turn it over to our board president, Kristen.
Hello. So thank you everyone so much for joining us today. I want to give a big shout out to everyone who's been participating in Accreta Awareness Month, sharing their posts, wearing their gear, raising funds, and tuning into this live stream and doing everything we can to get the word out about placenta accreta is one of the fastest growing life-threatening complications of pregnancy. And if you missed our 5K, I just wanted to say that there is still time to create a fundraiser, donate towards our Accreta Awareness Month Fund. I've got my swag here as well. Thanks, Jory, for the preview there. And one of the reasons that we are so excited today to bring Dr. Shainker here to our Accreta Expert Series is not only is he an Accreta expert, but he also has done extensive work to bring attention to the patient experience of placenta accreta. So some of you who've been in our patient community for a while, you may remember the first collaboration we did with Dr. Shainker and Beth Israel, and it was the What Does Every Accreta Mom Need to Know initiative. And that was back in 2018, and we had 108 patients and survivors contribute to that research, which we thought was just incredible at the time. And we did another survey back in February that just blew that one out of the water in terms of participation. So I'm so excited to bring Dr. Shainker here to tell us all about the results of these studies and just talk generally. You can ask questions throughout the stream as well. We've had some community submitted ones in advance to talk about this topic that unites us all today, placenta accreta spectrum. So welcome, Dr. Shainker. It's great to have you here with us today.
Thank you so much. I'm super happy to be here.
Awesome. So just for those of you who aren't familiar with Dr. Shainker's work, he's an MFM at Beth Israel Deaconess Medical Center in Boston. He's also a member of the faculty in the Department of Obstetrics, Gynecology, and Reproductive Biology at Harvard Medical School. He is the co-founder and director of the New England Center for Placental Disorders, which is an international referral center for women with placenta accreta. And he also serves as the Associate Medical Director of Labor and Delivery and lectures all around the world on reducing maternal morbidity and mortality, as well as specifically on placenta accreta. So, Dr. Shainker, such an honor to have you here with us today. I'd love to hear about your personal experience encountering and treating accreta in your practice. About how many accretas do you see a year?
Yeah, so first, thank you so much. I'm super excited. I've been working with Kristen and your group for a long time. And so my fault that I haven't been here sooner, but super happy to be here today. So, I think that is a little bit of a harder question to answer, actually, because I think we see a lot of patients who are referred to us because some concern for accreta or something happened in a prior pregnancy and they want to review risk factors for their next pregnancy, whether that's preconception or early on. And so those numbers are large. I don't know what they are, but they're, 50, 80, 100, something like that a year, something like that. And then and I think my actually most favorite day that I have in my work is when that patient comes to me in a pregnancy, concerned for accreta, concerned that of all the kind of scary things that we read in the lay literature and in reality with accreta, and we give them lots of reassurance that actually it looks pretty normal. Like that's a good day. And I send them back to their community and they deliver wherever they planned on delivering with their obstetrician or midwife or what have you. And then there are, I think for most of us who are experts in the field, there's actually a fraction of who get referred to us who have real PAS. And that number varies by year. It's somewhere around 20 to 30 plus a year that we're managing. And that's about where I think a reasonable number is to, kind of keep your skills honed and keep the team honed and kind of, and nobody really knows what the right number is, to be quite honest with you, but like that's kind of where we've kind of settled out. In Boston, there's a lot of there's a lot of hospitals in Boston, and so that number kind of gets diluted across the city, but that's about what we see here.
I'd love to hear that you're doing so much counseling for women who have risk factors for Accreta. That's fantastic. And that's just kind of a testament to the awareness work that has been done in terms of determining risk factors and really trying to target those folks before they get into those pregnancies and end up developing Accreta or not, which is great. So how do you feel that the amount of Accreta cases has changed over the years?
Yeah, I mean, it is, as you said, like it is rising at an alarming rate. I mean, I remember in my residency, we would see at a pretty busy trauma center in New England, we would see 1 or 2 a year, maybe. And, compare that to the numbers we're seeing now. And I think that, I think some of that is awareness, which is great. And some of that's attributed to your group. Some of that's attributed to some of the great work that's being done by other groups, including ACOG and SMFM across the country. And I think that there is very little doubt in my mind now that when people hear of Accreta or have concern that a patient has an Accreta, there is a general sentiment to get that patient to an institution that has expertise with that diagnosis. Where I'll tell you, when I was training in my residency, that was not the case. And I think we've made real progress there in the US. We still have a lot of work to do. But just the general respect for the disease, for lack of a better word, is much more apparent than it used to be.
And so one of the things, actually, one of our collaborations with you revealed, which I think everyone in the Accreta community knows and feels, but it was nice to be able to attribute a number to it, was how many people never hear the word Accreta until they're actually diagnosed with it. So I would love to hear from you, and both for our viewers who may not be as familiar with placenta Accreta, how do you describe it to someone who's never heard of it before?
Yeah. So I think I actually have a fellow who's on the call here who will attest. I say this the same way every time, which is, I describe the placenta and the uterus like Velcro, actually. And in normal placentation, the placenta and uterus separate, just like your kid's Velcro shoes. And in Accreta, take those two sides, the soft side and the rough side, and literally stitch them together and then try to separate them. And one side's going to rip. And so kind of that relationship, that interface between the placenta and the uterus is much deeper and adherent than it should be. I often give a fair bit of reassurance that shy of bleeding during the pregnancy, it actually doesn't affect people's pregnancy all that often. The health of the pregnancy, maybe there's some data that placentas don't work quite as well, but I think that the jury's still out on that conclusion, to be quite honest with you. But it's that deep adherence that I focus most of the counseling on. I purposely don't use the word invasion because I don't think that that's actually from a this is something that we study in our lab here. Like from a biological perspective, that's not what's happening. It's not growing like cancer. Like that's not. These cells are normal. They're just too deep into the wall, usually as a result of some prior surgical, scar, C-section being the most common, as you know. But that's usually how I describe it.
And that is actually a shift too that I've seen over the past few years, is going away from this invasive mentality and more towards understanding what is causing these placentas to behave in this way. So something we can get into a little later in the session today as well. I would love to hear, so how did you end up focusing your career on placenta Accreta?
Yeah, it was an interesting journey. So, I knew I wanted to take care of a population that required kind of critical medicine, critical care, and complex surgery. And as you're going through OBGYN, there's kind of two avenues that goes down. One is take care of GYN cancer patients, and that wasn't really my passion. I loved obstetrics, and I knew I wanted to do MFM or become kind of Accreta specialist. And that terminology was kind of just becoming kind of an option, I guess, or that title was just becoming an option as I was in my training. And we set up a program during my fellowship here, and somewhat out of necessity. I mean, as you said, Kristen, like the numbers just started to blossom, and we needed systems in place to care for those patients safely. And so we very quickly put together a program which has really, grown, particularly the research arm of it. And so somewhat out of necessity, somewhat out of like true interest. And then, I really enjoy the counseling component of this, of Accreta. I mean, I think that when the patient comes in, and I think you can probably speak to this yourself, from a community hospital or from talking to a doc who hasn't managed a lot of these and has really put the fear of hemorrhage, including death, in a patient's mind, my first job is to kind of give them appropriate reassurance and reassurance that, this system works that we've put together and we're going to keep you safe. I do a lot of hand holding, like physically holding hands. My patients will attest if they're on. I think that's, having that kind of ability to connect with patients in this real dire moment of fear is a privilege. And it's a privilege that I really enjoy doing.
Oh, that's so well said. Thank you so much. I was going to ask you what the most gratifying and rewarding part of your role is, but I think you just gave it to us.
Yeah, that's definitely it. And I will say, like, I think that the second most though is teaching that my trainees, my residents and fellows, like that's how you should talk to patients. And I think that, I get a lot of time to talk to these patients, which I'm also quite privileged about, quite a privilege. But it's clear that there's a connection there. And when I talk to my, my colleagues across the country, some of which have spoken on this before, I think we all view that as a true privilege. And, our ability to teach the next generation on how to make those connections and the power of words with our patients is really, can't be understated.
And it's so important. I mean, as Accreta goes from this niche diagnosis to something that we're seeing more frequently, making sure that we have folks who are trained to not just handle the medical complexities of the placenta Accreta delivery and aftermath, but also the patient experience side of that as well, which is clearly something that you've spent a lot of time engaging in the research on, which is very important. We'll get into that. I keep like teasing for our session. I'm very excited for it, but I do have a few more questions first.
Yeah, of course.
What is the hardest part of your role?
Yeah. I think when things don't go well, like I think talking to families when patients are critically ill and still giving them reassurance, but, I think there's always that, that sense of pause that, there's some unknowns on what the future brings for people. And whether, this, despite all our best efforts, people can still have bad outcomes. And continuing that trust and being honest and having kind of faith in my own team that will get the patient as well as the family through whatever situation, that although that's very gratifying, that those are hard days. When Accretas go well, they're great. When Accretas don't go well, there's a reason why not everyone does them. And I think that I'm sure you have survivors on this call who have had, that may be triggering, and I'm sorry, but I think that we all know what I mean by that. I mean, I think unfortunately there's people who don't survive this, and that's a small number, and that should be a small number. I personally think that's less than 1%, at least at a center that has a reasonably high volume and systems in place to take care of these patients. But I think unfortunately we've lost people in this community, and that in the Accreta community, and I think that those are really hard days.
Absolutely. And that's part of what really fuels us in our work as well, is to make sure that we are doing everything we can to get the word out about this condition, to be helping to advance the research, advance treatment, get women diagnosed, to get them to the right places, and get the best outcomes possible that we can for everyone.
Absolutely.
So I always like to ask this question: what job would you have if you weren't an MFM?
Yeah, I'd be a park ranger. Yeah, it wouldn't be medicine, I'll tell you that. I would be, a wilderness in the bush somewhere, keeping the earth safe. That's what I'd
Keeping the earth safe, going from keeping mom safe
Yeah.
to keeping Mother Earth safe.
Yeah.
I like it. On brand.
There are days that's a very appealing job. But I think, I tell my fellows and residents every day, I think I have the best job in the hospital. So I really enjoy doing what I do. But if not, I'd be in the woods.
And what would people be surprised to know about you?
Yeah, there's so much. What would be people surprised to know about me? I think the park ranger is a little bit surprising.
Yeah, I know.
I have a real interest in hiking and doing long distance hiking, and have spent some time on the Appalachian Trail. Have plans to do Tour de Mont Blanc at one point, hopefully with my kids, which would be super cool. Which is a tour around France. I think it's France, Italy, and Switzerland, around Mont Blanc. And then at one point, the Pacific Crest Trail would be amazing. So, yeah.
Awesome. Very cool. I hope you get a sabbatical or some time to fulfill your hiking dreams.
Yeah, it might be retirement, but that's okay.
Well, with that, I would say let's go ahead and hand it over to you for your presentation today.
Great.
Thank you so much.
Of course. Thanks. That was fun. Let's see. Hopefully this works. So this Kristen, just confirm this is in presenter mode for me, yeah? You can see my slides?
Sorry, yes, we can see your slide. You're good.
All right, great. Sorry. All right. So, as I was thinking about what to talk about, I couldn't think of a better topic than the partnership that we have created with NAF, which has really just been really rewarding from my research team's perspective. We've learned a lot. We've gotten some great engagement with the community. And all the work we've done is we've worked with Kristen and her team and others into like refining the questions and making sure they aren't triggering, but getting the right information. And so we've learned a lot about our own methodology and our ability to ask questions. So thank you to NAF for that partnership, and it's really been great. And so just like any other regular discussion or regular talk, we talk about disclosures. These have absolutely nothing to do with this talk. But really my biggest disclosure is that none of my work could be done without you, the patient. And so I have a deepest sense of gratitude and thanks for you giving your time, for you trusting this community with your information, and know that we respect it and treat it very delicately. And hopefully, as Kristen said, we'll move the needle from a research perspective in improving care for patients and their families. So the first partnership we had resulted in this paper, and as Kristen said, it actually took a really long time to get to this point. So we started these discussions in, I think, 2018. And then there's like this little thing called COVID that came along, and so kind of like everything went to a back burner. But we did finally get this published. And what really sparked my interest here was kind of and I was hearing this from our patients in Boston, like what they would say, what information can I provide to people who are going through this that would help them? And so we were like, okay, well, let's take it one step back and say, let's talk about how patients perceive their care and how they think the team did. And this is nationally, actually internationally. And what did the patient, the survivor, think was a consequence from their PAS delivery? And so we did this survey-based study. It was tons of fun. Happy to report both the trainees on this paper. One's off to medical school, one got her PhD. So like you have helped these people move along in their careers, which is really great, something I'm very proud of. The objective of the study was to describe the patient experience, have the patient report outcomes. This is the first time this has ever been done in the PAS community. It's actually relatively rare, even in the obstetric community, to survey patients to report their outcomes without corroborating them in a medical record, which we didn't have access to, right? That's kind of the unique thing about this this disease. It's a relatively rare disease, and there are some research centralized databases, but there's not there's not kind of agreements among all these hospitals to get access to medical record. And so this is the way we did it. And then what I was really interested in, and very pleased with the results, and I'll share them in a second, was that were there significant geographical variations in the care of PAS? And that, again, is reported by the patient, which is a very unique spin on this. So the surveys-based study, and thanks to NAF and thanks to all of you, maybe some of you contributed to this, we had 108 responses, almost a 70% response rate, which is really just fabulous for a survey. And it was our first survey with NAF. And so we're super happy about that. And so we came up with some pretty interesting results, which I've highlighted here. We looked at it in kind of 3 buckets. So if you look, I think you can see my cursor here. So these were all responses. We only included US responses, so 103, these are from the US. Broke them down into census districts, which was an easy way for us to manipulate the data. It's been done in other studies. And I wanted to know kind of what work was done for the patient to think that she was finding the best care that she could find. And so kind of just ask the question, did you research dedicated PAS facilities? The first thing, about 50% did. This is after receiving their diagnosis. We don't know if the other 50% were already at a place that they felt comfortable with their PAS team. So that's a little bit kind of a consequence of the methodology. But as you can see, there's no big difference across when comparing the South and West, Northeast, and Midwest. And so the p-value there, less than 0.5, would be significant as we look for differences amongst those answers. And there were none. And then this, I was actually pretty happy to see, did your PAS care team change? And so we were hoping that this was going to be a very large number. It is, ranging from mid-80s to nearly 100% in the Midwest. And so this is now meaning that outside of the research methodology and outside of what we're practicing and practice guidelines, that people are actually practicing what they preach. That if a doc was seeing a patient or a midwife is seeing a patient and they have PAS, then the patient is going to a place where there's a team that takes care of PAS patients. And we were seeing that consistently, which is really, really great. And the next question is similar. So was your PAS managed by a dedicated team or program? Again, pretty robust numbers there, 70, 80%. And then the last one, we were curious kind of the burden of this on moving. And so did you have to change your hospital? And I think most of the people on this call probably did, just based on the survey results, that most people do wind up having to change their hospitals. I think that is, I'm always sensitive to when patients need to change their hospitals. I know it's a burden to the family and get them out of their community, and that is less than ideal. But we can't have patients having planned PAS cases at every hospital in the country. That's probably not the best system. And so this was our way of kind of answering that question. And then I think what was really reassuring was the last one was, did you think your care team was prepared? When overwhelmingly people said yes, which is, from a person who delivers care, from a surgeon's perspective, this is what we want our patients to say. We want them to feel comfortable in the care that they get and that they felt that we were prepared, which is really great. And then the other thing we were really interested in was, what about adverse outcomes? So what did the patient report as an adverse outcome as attributable to the PAS? And so the first one was, did you report some adverse outcome? And that's both either mental or physical. And again, about 60 to 70% said yes. Again, there was no differences across geography at all for any of these questions. The first one was physical. We left that purposely vague. We got a couple of free text answers. Some are still reporting a fair bit of pain. And the average length of time after delivery, or the median length of time after delivery to when they filled the survey, that was about 3 years. And so the question didn't say at time of delivery, did you have the adverse outcome? And the question implied, are you currently still experiencing it? And so, overwhelming still have some physical complaint. Pain was the biggest one. And then bladder, and when we got down to some specifics, bladder injury. Again, I don't I think it was a problem with the question, to be quite honest with you. I don't think that 50% are still complaining of bladder issues, although it's possible. That's not my experience here with my own patients. Certainly people have bladder injury as a result of the surgery, but I don't think that we have 50% of patients still complaining of bladder concerns 3 years later. And then we were a little bit surprised about the sexual dysfunction. Brett Einerson, my friend at Utah, has reported on this in a different survey. He found much higher numbers in sexual dysfunction adverse outcomes. And so our numbers were pretty low. There's always a concern about asking questions about sexual dysfunction and how that's perceived and patients' ability to be forthcoming there. So I'm not quite sure if we really got the gist of that question, but it was worth asking. And then I think consistent with what we're seeing across a bunch of other studies, particularly the group out of Ireland looking at mental health, about 15 to 20% reported some mental health toll as a result of their PAS delivery, PTSD kind of driving that. These numbers are actually a little bit smaller than what's reported in some of the other studies. But again, we only had just over 100 patients. And so this, what we concluded was that perception of care and outcomes are overall favorable, which was great. Like, we really didn't know what patients were going to say about their care across the country, and were there going to be disparities as it results to geography. And I was very pleased to find that that was not the case. And then we did find that there are long-term physical and mental health adverse consequences as a result of PAS, and that national guidelines were predominantly being followed as it relates to getting to a PAS center, getting to a care team that has experience. And then we asked some anesthesia questions I didn't report here, but they were being followed predominantly, which was great. This brings us to our second partnership, which was much more robust. And again, thanks to NAF for all their assistance in developing the questions. And so it was one large survey. Thank you for those who filled it out. It was fairly long. We had 4 major objectives. And so the first was to investigate the breastfeeding experience and to identify risk factors impacting breastfeeding with PAS. That was led by one of my dearest colleagues, Uma Deshmukh, who's one of my partners here. The next was to understand the impact of peripartum hysterectomy on the maternal-infant bonding. That was led by my graduating fellow, Bridget Donovan, and that has subsequently led to another survey, which I'll tell you about in a few minutes. And then my 2 research assistants, who are both moving on to graduate school. Again, thank you for contributing to their ability to contribute to the literature. One was looking at the impact of pregnancy complications on general anxiety disorder of patients with PAS. We'll present that data as well. And then the last one, which this is going to be presented at the Society of Maternal-Fetal Medicine this year, and I'm happy to report that NAF as well as Placenta Accreta Ireland are on that publication to evaluate the effect of pregnancy complications on quality of life. I'm not going to report that just because we're not allowed to report that publicly until it's presented at the conference. So we'll talk about the first 3. The first thing is that we went from 108 responses to 440 responses, which is really just amazing. It shows NAF's impact globally. So thank you, as well as Placenta Ireland. And so we want to just get a general sense of like who was answering these questions and when in their life. And so first, like, are you, where in your COVID journey were you? And so this was done in February, as Kristen said. It was open for about 6 weeks. So 400 responses in over about 6 weeks, which is pretty awesome. And so were you answering, was your pregnancy delivered post-COVID, which we defined as whenever the pandemic officially started, I forget the exact date, to current, or pre the pandemic? And so about 50% was pre and post, which was nice because we were able then to do some analysis, figuring out, did COVID contribute to some of our concerns as well? About 50%, a little bit over 50%, had an antenatal suspicion for PAS, which, although that's what's reported in the literature, I do find that a disappointing number. I think my hope is that we should be able to do better. We do better in research studies, and so it's unfortunate that we're not identifying patients during the pregnancy opposed to that time of delivery, but our diagnostic abilities are still somewhat limited. The majority did receive a hysterectomy. Just under 50% result in the ICU. Neonatal complication, that's neonatal ICU admission and something else. And so we didn't actually delve into what that was, but it could be hypoglycemia, it could be respiratory distress syndrome, it could be something else related to prematurity. And then NICU admission, and that's driven by gestational age, almost certainly. Race ethnicity, the predominantly was white, although we do have some diversity, but very, very little. I think that is a huge limitation of doing surveys like this. But our group is going to kind of expand internationally, hopefully soon, to try to get at least more of the Hispanic and maybe Asian voice here to better understand the experience. And then socioeconomic, again, most were living in the US, most had full-time insurance, most had a college degree or higher, and the overwhelming were married. And this is just trying to get a sense of their kind of socioeconomic support. And so the first question asked, did your PAS delivery affect your ability to bond with your newborn? And we dichotomize that into for those who had a hysterectomy and those who didn't have a hysterectomy. For both of them, both the HIS group and the non-HIS group, yes, they do attribute that their PAS delivery or their PAS diagnosis affected their ability. We got some free text saying there was a delay in me being able to hold my baby, delay in skin to skin, all things that we experience in real life, and we try to overcome. I've had patients donate iPads, so if a patient's in the NICU and mom's still in the OR, she's FaceTiming with the baby while the baby's in the NICU, which is really incredibly generous gift by a prior patient, and we use them all the time. And I would encourage some kind of creativity at other institutions to do the same. There were a couple of other interesting bonding questions, but this was the one that was really most significant when we looked at whether a hemorrhage affected bonding or whether ICU affected bonding or NICU admission affected bonding. Nothing else really panned out. It was actually just most people just reported the PAS delivery itself, not the individual subsets or outcomes of the PAS delivery. And so we're still trying to tease through that data. We're writing the manuscript now. And once we have it published, I'll have Kristen send it out to the group. The next was breastfeeding. And so a couple interesting things. So first, I was pretty pleased to report that most people actually met their goal. And most of that goal was to have some exclusive breastfeeding while in the hospital. Despite overwhelming meeting, or the majority meeting the goal, there's still about 70% who had some difficulties and most of those felt that their PAS diagnosis interfered with their ability as planned. So still meeting goal, but it made it a little bit harder is I guess how I would interpret that. And I think a lot of that is NICU admission as a result of the current recommendation, gestational age of delivery in the US. And if you're having a hysterectomy, you're in the operating room longer, and your ability in that golden hour to get the baby to the breast and get the baby breastfeeding, particularly when there's prematurity involved, is harder. And then for those who didn't meet their breastfeeding goals, they were more likely to have some other diagnosis. And so preeclampsia was one, which is hypertension in pregnancy and some renal issues. Depression is certainly one. Anxiety, again, we looked at those, and then multiples. And I think multiples in general have a harder time of breastfeeding. And so we didn't have enough numbers to kind of control for that, but worth delving into, and we're in the process of writing up this data. The general anxiety disorder data, so we use something called the GAD-7, which is a kind of a validated survey investigating general anxiety. And so the first is, it's just notable that 60% screen positive on the GAD-7. So 60% of patients reported having, although maybe not identifying as general anxiety, based on their responses, they do meet criteria for general anxiety after their PAS delivery. And then we kind of delved into the ones that contribute significantly to that. One was, so if you had a planned delivery, if you had an unplanned delivery, you were more likely to have general anxiety disorder postpartum. So if your delivery was performed on not your scheduled date, whether it was in the setting of labor or bleeding or what have you, that put you at a higher risk of developing general anxiety disorder. If you had a postpartum hemorrhage, as you can see, about 65% of those people reported positive for on the GAD-7. That's this column right here. Interestingly, when we looked at hemorrhage and then transfusion, if you got a transfusion, that did not increase your general anxiety. if you got a hysterectomy, that did not increase your general anxiety. So it's just the idea of you identifying of having a hemorrhage, then those patients were more likely. If you had an ICU admission, I think we see that outside the PAS community too. There's some data out of Europe in the OB community. And then COVID is an interesting one as well. If you were post-COVID, you were more likely to, if you were pre-COVID, you're more likely to have general anxiety. And, I've been thinking about why. And the only kind of thing I can kind of put my brain around for that is that maybe during COVID, we were just so anxious about everything else that we didn't attribute it to PAS if I was the patient. And so, whereas pre-COVID, we weren't living in a pandemic and we were able to focus on that PAS experience much more than during the pandemic where other things were really distracting and just generally making us anxious. That's kind of the way I can put my brain around that. Our next step is, I think, the most exciting thing we've done, at least the most exciting partnership we've done with NAF yet. And I need to put a plug in for my fellow, Bridget, that's her right there, who is really interested in understanding the maternal infant bonding, mental health and breastfeeding kind of experience, if you will, of women with PAS. And so this is my shameless plug that if you are pregnant with PAS and you want to contribute, this link should be live very soon. Kristen's going to send out a blast and it will be on the website. It's 2 surveys. It's a survey, one during the pregnancy and one at postpartum. We are comparing some different validated surveys looking at maternal infant bonding, breastfeeding, and mental health, and look at kind of what people's intentions are compared to what reality is postpartum. I think it's really exciting. Kudos to Bridget for coming up with some really great questions. And thank you in advance if you are interested in participating. I do a lot of other research. We do a lot of biomarker research. We do a bunch of epi work. Anna Modeste and I partner a lot looking at IVF as a risk factor. Jonathan Hecht, who's an international placental biologist, he and I do a lot of work together. And all of this, as you can imagine, is not cheap. And so I have some funders that have been incredibly generous in funding my work, and I'm incredibly in debt to them and gracious for their time and money. I think our future for NAF and my research team's future is bright together. I mean, I think these are questions that we can only answer together. We can't just answer in the local Boston area, and even the local kind of just PAS research community can't answer this. So, PAS Square, which is a great organization doing really great work, and we partner with them. We need to get outside the research community and get into the community hospitals and get into, health workers and get into really who's helping counseling patients. If you have questions, please email me. I'm happy to answer emails. Reach out to me. I'm happy to set up a call or a chat or whatever. And if you're interested in participating in Bridget's study, please reach out to Kristen. She can help facilitate that. That will be live hopefully next week. Kristen, I don't know if there's questions. I'm going to stop sharing my slides here.
Yeah. Well, thank you so much. That was awesome. And I do want to give a shout out to the folks who are with us today, who are watching, who are currently pregnant with suspected placenta accreta. We do have a page, a call to action page for this event that we'll be sharing in the live stream and out after as well, where we have a sign up form where you guys can tell us that you're interested, give us your info, and we will make sure that we notify you when this study is live. We've just been so impressed by the amount of community participation and research. And it's so important because there are some things, one of the things that's so great about our groups and getting the community together is there are things that we understand having gone through the Accreta experience, but it's hard, I think, and Scott, I'll be interested in your thoughts on this. It's hard to convey that in an academic and impactful way to make change in care without having an official study putting numbers to that and giving legitimacy to that. And so that's one of the things that I'm so grateful for about these collaborations that we do, is it gives us the opportunity to invite you, the community members, to have your voices heard and to be part of this really official way that we can channel our experiences into directly making change for future moms.
Yeah,
So thank you.
yeah, I couldn't agree with you more. I think that I think we're just kind of addressing the tip of the iceberg and understanding the toll that PAS has on, most of this has been focused on the patient, but I think there's a big family toll that needs to be explored. And I mean, I see that with patients, partners, and kids, and parents, their own parents. I get big hugs from grandparents all the time, which is great. But understanding kind of what the family unit's going through, no one's really looked at that. I think there's a little bit of data out of Ireland on that. And then I think that the other thing, and I think Helen Bartel has done this really well in Ireland, is she's done some qualitative work and kind of doing sit-down focus groups and interviews. And some of you and I have been at talks by her, and that some of those stories are really just, there's not a dry eye in the house. So I agree with you, and thank you for the partnership and the trust.
And it's interesting to say too, I think you wrote, or it was written in the first study that we did together in 2018, that there was only one publication prior on patient experience in placenta accreta. And the interest in this has just like exploded over the past, maybe paralleling increased rates of accreta actually. But I am so optimistic about just this academic interest in better understanding the patient experience, patient and family experience of this diagnosis and this treatment. So I'd love to kind of move on to some questions in terms of the on the ground, people who are actually treating accreta patients. What is the impact of publishing research like this? Like, how does this get translated into informing practices and care?
Yeah, so I've been fortunate to be part of that. I think when we do, for those of you not in the research world or the academic world or what have you, the goal is not to get the paper, right? The goal is to kind of move the needle in terms of care, if you will, right? And so that's what motivates us. And so, we were I just chaired a group that SMFM put together, Society of Maternal Fetal Medicine. It was 7 organizations, international, global representation, using published data. Probably many of you were imaged in the studies and you never knew it, to be quite honest, because these were studies from all over the world, to be quite honest with you. And we looked at all the published data and came up with the kind of most common ultrasound markers for patients with PAS, create an international task force, international guidelines. And so those have changed practice, right? In fact, I was just in Korea last week presenting those. And so, that is a highly cited paper, and people reference that paper, but that started as some very small, now somewhat older or somewhat more modern imaging studies, and it's really changed practice. And I think we've seen the same with some great data out of Europe in terms of management. I think the standard of care in the U.S. is still a hysterectomy, but I'll be quite honest with you, I think that's going to change soon. I'm not saying that everyone's going to get conservative management, but I think it's going to be the way we counsel them is going to change. I feel pretty comfortable. I think it's already starting, to be quite honest with you. And so, as it relates to some of the patient surveys and the mental health piece, I think having a mental health provider as part of your PAS team now is almost obligatory, to be quite honest with you, if not obligatory. I mean, we have a dedicated social worker for our patients, and it's really an opt-out. Like the expectation is that she's going to reach out to you unless you tell me you don't want to talk to her. And I make a strong case for why she is a helpful resource. And I don't know, 90+% of patients will agree to, and then when I see them in follow-up, they're so grateful for her as a resource. And so I think that we are contributing to care with this research in real time, right? Some diseases that we are still kind of that we've known a fair bit about. I think in our lifetime, we're probably not going to see huge changes in the care of hypertension or heart failure, or, kind of things that we've known a lot about over the years. But as you said, PAS is a relatively new disease, at least in terms of the numbers that we're seeing it. And so we have to do better.
That makes me think I need to have you back on another session for us, Dr. Shainker, where you go through the history of
Yeah, I had
BAS from
that
your
talk.
session.
Yeah. It's a fun talk. It's a fun talk. Yeah.
It is.
Yeah.
That's a great one. So I do want to say too, after you kind of tease some of these topics outside of patient experience that I do want to touch on, biomarkers. So we do get a lot of questions about diagnostics in general, and then there have been some just news articles coming out, probably as a result of some of the studies you and others have done about there being the capacity to potentially predict placenta accreta in the future with blood work. So I would love if you could tell us a little more about that.
Yeah. So I think we are getting closer. I didn't say close, but we're getting closer. I think that there's certainly a precedent in the obstetrics community to find whether it's a protein signal or some biomarker in maternal blood. In fact, many of you have probably done this. You did a glucose screen. You did a Down syndrome screen. There's now one out there for preterm birth. There's going to be there's a preeclampsia one out there now. And so there's a precedent for proteins coming from the placenta to identify patients at risk or help diagnose a certain disease. And so we did a pretty robust proteomic study here at BI and continue to work on that. The first study was the third trimester. We have robust multi-center data coming out now in the second trimester. First trimester is a little bit harder, but you can get cesarean scar pregnancies. The problem is that the placenta probably isn't big enough yet to send out enough proteins. And so I think that there's a scenario in the not too distant future where there's a calculator, just like we used to do for Down syndrome screening, where we used to measure the nuchal translucency and look at certain protein profiles and say, here's your risk for Down syndrome. Now we measure certain profiles, we take some surgical risk factors or some ultrasound markers, and we say, here's your risk for PAS. I think it'll be really good at lowering one's risk. I'm not sure if we're going to ultrasound is pretty good in the right hands. And so I'm not sure how much better we're going to get than diagnostic imaging studies to improve the diagnosis. But again, I think I told you, like, one of my most favorite days is telling the patient to go back to your community. I think you're fine. Yeah. And if we had some biological framework to support that, not just imaging, it would be even more robust. So I think we're getting there. There's some really great work being done at UCLA. The Brigham's doing some great work. We're doing really good work. There's some groups in China that are doing strong work. And so we're all kind of looking at it slightly different focus, but we'll get there. We'll get there. It's as you can imagine, it's very, very costly to do this. And so the funding hasn't quite been there from the NIH to do it, unfortunately.
Is it something where it could be another just piece of data, an indicator in the early on in pregnancy to just get those women to getting those high value imaging, so that, because I think that's what we're looking for from a patient community, is how we can intercept these women who are at highest risk of Accreta early on and make sure that they get diagnosed and get to appropriate level of care, right?
Yeah. So I think the perfect patient for a biomarker is, somewhere in the second trimester who has a placenta previa. Like, I actually wouldn't even add surgery. I would just say you have a placenta previa, right? We know that some of those patients, even in the absence of surgery, about 3% or so, are going to have Accreta based on older data, but it's still the best data we have. And we certainly see that. And maybe you add IVF. There's a question about IVF here in the chat. Like, maybe you add some other emerging risk factors. And we do think that IVF and probably frozen cycles is bigger than fresh cycles. We don't quite know why, although there is one study looking at that. And so as we kind of tease out what those other risk factors are, we create this calculator. And so, yeah, Kristen, I totally agree. I think the whole purpose of the biomarker, or whatever the improved diagnostic tool is going to be, is going to ensure people getting access to the right location of care. It's not going to do
but
anything.
The way you're doing, yeah, the way you're describing it, it really is actually a lot of different things. So it's not just a biomarker by itself. It's really the biomarker plus the patient history plus a lot of different factors that help feed into this assessment. Okay.
Yeah, I think
helpful.
so. You know, the publications that are out there don't take those things into account. They just look at the protein signal or the Velcro signal, or whatever the studies are looking at. But I think that's from a research perspective. Like, you know, I think we can do better by taking all that patient information in, right? Because they're so expensive, we're using such like a pure cohort of people. That's not reality, right? Like, if you use patients with prior cesarean deliveries and they all have previas, yeah, your test is going to work really well, but that's not life, right? Like, you know. And so I think the more we can kind of add to these calculators, and there are people working on this, you know, across the country, and they'll, I think as we improve the biomarker, we'll put them all together and improve diagnosis. But I do think we have to do better than the 55% antenatal diagnosis that the first study showed. We have to do better than that. Like, we are, as a community, we're better than that. I think we owe families better than that. And so that's kind of our motivation to do biomarker work, is that we need to improve diagnosis. That should decrease morbidity and then ultimately mortality. But that's where I think we can really make a difference.
Awesome. I can ask you questions all day, but there have been some fantastic ones coming in from our viewers in the group chat here. So Jory, I'm going to let you kind of take it away with asking some community questions.
Yeah, we had some submitted in advance, and we also have some great ones coming in live during the stream. So I wanted to share this on your kind of research approach. Jamie asked, well, first, Jamie said, I love the idea of involving the community in your research and then returning the research, which is, of course, what we love about our connection as a survivor and patient community with providers and researchers like you. And she asked, how can you expand your research to include more U.S. women of color and women with public insurance or Medicaid who often report different or disparate experiences within the healthcare system? Thanks for your time.
Yeah, thank you so much. It's really a problem with a lot of this PAS work, is that we haven't engaged with a very diverse community at all. I will say that I'm proud to report that our biomarker data here, our biomarker cohort here, is actually pretty diverse, which is great. But that's not what we're seeing nationally. I don't think that race is a risk factor for PAS, like flat out. And so I think that that doesn't make biological sense. You know, unfortunately, we know that cesarean section rates are higher in women of color than white women across the country, and that's probably more racism than some biological explanation for that. But shy of that, the actual development of PAS should not change by race. And so, if the NIH funds studies, or there's government organizations that fund these studies, then you're kind of obliged to somehow improve your engagement to represent more of the population of the U.S. You know, that although that's people's motivation to get a cohort as generalizable as possible, we haven't done a great job. And so I think partnering with NAF and, you know, I think partnering with doulas and partnering with healthcare workers and midwives and health centers, federally qualified health centers, to really improve the catchment and to improve diversity in these studies is critically important. We have federal qualified centers here, and we have patients who've enrolled in our studies through those. And so it is an uphill battle, but we're working on it. But we're not doing a good enough job.
Thank you for that. We have a couple of questions, some that were submitted in advance by nurse practitioners or providers, and some that have come in during the live. And they kind of go to, I'm going to try and summarize them a little bit. You know, some of it is conversation about, well, on the front end, you know, what advice would you give to providers that are trying to advocate within the provider community about patient safety and kind of fully disclosing and discussing risks and concerns with C-sections in particular and other uterine surgeries. And then on the back end, you know, post-uterine surgery, what what do you see happening, or what do you think is important to improve, how providers are providing patient education post-surgery? These are, to be aware that this does increase your risk down the road for this and that.
Yeah.
So if you could reflect and share with viewers about
Yeah.
that.
Those are great questions. Things we struggle with on the labor floor, I think, daily, to be quite honest with you. I think it is hard to do full comprehensive counseling in the moment while you're recommending a C-section in an urgent setting, right? Like that's something I, do on the labor floor regularly. Take care of laboring women who, for whatever medical indication, not elective, what's called a fetal indication, there's a fetal heart rate goes down. It's hard to include full Accreta counseling in that moment, right? I think that we do try talk about downstream effects of the cesarean section to reproductive health. But certainly there's a responsibility for after the delivery, whether it's still in the hospitalization, whether it's, at that visit, whether it's patient handouts, something needs to be done. And I think we do a reasonably good job here of, you had a C-section, here's what we would recommend for like inter-pregnancy interval to avoid risk of X. You have a C-section, you have an increased risk of Accreta in future pregnancies. Again, I think because we do a fair number of Accretas here, it's on the forefront of most of our mind. I think that's probably not 100% true across a smaller volume, smaller community hospital is my hunch. But that's an excuse, not a good excuse. And so I think that, there's patient education that ACOG provides. There's probably patient education that NAF could provide, to be quite honest with you, of risks of a prior C-section in a future pregnancy. That's a pretty short list of things that we could put together. And I think there's a community of, my PAS friends that would probably be more than happy to help contribute to that patient handout and make it as, factual and evidence-based as possible. But the patient who comes back for her second pregnancy and has an Accreta, more times than not has never heard about it. And so that's the problem. Like they're blindsided, like somebody wrote here in the chat. And so, I've never heard of this diagnosis until I was told I have it. Because it's so rare, even if patients are counseled, we don't dwell on it. And usually they haven't heard it from their family, they haven't heard from their friends, and they kind of forget about it, right? And so it's going to take more than just in the moment counseling. I do think, as it relates to the provider, I think that we do a really good job of, as a community, of policing ourselves to minimize the cesarean delivery burden across the community. And the days of doing, kind of elective cesarean deliveries, because, that's the day the doc's on labor floor. I want my doctor to deliver me or something. Like I would strongly encourage people not to do that. Like we know that it is absolutely safe for in almost every circumstance to have a vaginal birth, and certainly has a significant risk reduction for future pregnancies. And so, 80+% of PAS cases are a consequence of a prior cesarean delivery, something like that. I think that's the number. And so if we can reduce the unnecessary cesarean deliveries, we should see a significant reduction there. And I think
prevent Accreta button.
There you go, prevent Accreta. I do think that there is a push nationally with from ACOG and SMFM, and probably A1 and probably the midwifery community. I'm just less familiar with those, to do the to avoid the unnecessary cesarean delivery.
Yeah, there's been a lot of initiatives in the past 5-10 years or so to decrease the overall C-section rate and make sure, especially for first-time moms, that we are supporting vaginal birth whenever possible, because is it fair to say that that's the biggest way to make impact in reducing rates of Accreta downstream?
Yeah, I mean, I think that there's an impact of making initiatives. I think that there are, there are other metrics that are measured by kind of Leapfrog and JCO and other kind of governing credentialing bodies that look at cesarean section rates. Um, I'm not aware that they're holding money aside for those types of things. Like, that's not where my focus is at all. Maybe they are. I honestly, I don't know. But I think that the more multifaceted way that we could draw attention to it, and so whether it's those agencies, whether it's inundating people with education from the initiatives of our national organizations, whether it's patient advocacy, whether it's government, I think the more the merrier, to be quite honest with you.
And Kim Kardashian,
Listen, that I will say, like, I had when that happened, and that came out in like People or Cosmo, or I don't even know when it came out in. I had patients bring me the article, and they were like, "Is this is this what I have?" And so it was an opportunity to start a discussion, right? I mean, I'm glad she's safe, but again, like, she probably helped families, not even realizing that she brought this to the forefront of discussion. So, but yeah, right. We can joke about it, but yeah, absolutely.
Yeah, Kim, if you're watching, we'd love to send you a shirt or something. Please reach out to us.
Yeah.
Well, we had a couple of questions come in advance, and to be perfectly honest, they surprised me a little bit, but I think they're driven by a real interest in, trying to control as patients what we wish that we could control, right, about our situations, and how can we contribute in any way possibly to better management or better outcomes for ourselves. So I'm going to read both of them, and they're kind of related. One was, can pelvic or bed rest slow down the progression or severity of placenta accreta? And then another question was about any other options to decrease the chances of accreta for those with previous C-sections. Are there any kind of prenatal behavior before conceiving, diet, exercise, etc.? So, just a real curiosity among the community about, do we have something that we can do for ourselves as patients?
Yeah, I think, let me answer the second one first. I think the only risk factor that is probably modifiable that we have identified is smoking, to be quite honest with you. So if you need IVF, you need IVF, right? Like, if you want to expand your family and you can't get pregnant naturally, you need IVF. So I actually don't view that as modifiable for many families, right? Like, they want to expand their family, they don't have another choice. Surrogacy, I guess, is the other option, which for many families is not an option, or adoption. Which I don't want to belittle either of those, but if they want to naturally carry a pregnancy. We have found, and it doesn't make any biological sense to me, I'll be quite honest with you, but smoking is a risk factor for PIF. I don't totally know why. We do a lot of kind of pathophysiology studies, and smoking reduces one's risk of developing preeclampsia. And preeclampsia is like a shallow. I know, I'm not suggesting anyone smokes to lower the risk. Like, be very clear. I'm not giving medical advice here. But it is a risk reducer for preeclampsia. And so many of us think that preeclampsia is a very shallow attachment of the placenta in the uterus. So the Velcro is like just barely touching, right? Whereas the opposite is accreta, and it's very deep. And we've done some studies here at BI, and other people have done them as well, looking at certain preeclampsia markers, and they are expressed differently, like 180 compared to preeclampsia and PAS. And so, listen, I think everyone should probably quit smoking, but that's easier said than done, right? If that's your crutch. But potentially, stopping smoking is something that you could do. Interpregnancy interval is another one. And so letting that scar really heal. We don't quite know what that amount of time is. It's probably at least a year, and probably getting to 18 months, you probably minimize the risk reduction as much as possible. Maybe waiting 2 years is better, but it probably doesn't provide much more benefit. So kind of 18 months seems to be that sweet spot. Again, 36 months is fine too, but you're probably not getting improved benefit by waiting that long. people have looked at suture, like what suture was used, the closure type, all sorts of like different things that are really hard to study in the moment. Nothing's really panned out. One layer versus two layer closure hasn't really panned out. Excuse me. Pelvic rest is, or bed rest and pelvic rest, and like those are not going to affect your risk of developing Accreta or previa or anything. I think many people practice pelvic rest, nothing in the vagina, if they have a previa, and that's a conversation for you and your provider. But it's not going to affect whether or not you get an Accreta or not. Like the placenta is going to implant in that scar, whether you go do all your Kegel exercises or not, and probably whether you smoke or not, to be quite honest with you. Maybe IVF increases that risk. We think it probably does. And our data says about 5-fold increased risk compared to the general population. Other studies a little bit higher, but it definitely is higher. We don't, again, biologically, we're not 100% sure why. We have some different theories, but, and again, frozen looks like the risk factor is a little bit higher than fresh for cycles, but there's not a lot you can do, and there's really nothing your doc can do once you have it, unfortunately.
That makes me think of one of the questions we got asked in advance, Jory, the one about, this is from Allison. I was wondering if you could discuss Accreta after multiple C-sections in the absence of previa. I've heard conflicting things about the odds of it occurring. What makes it more likely to occur? And how can we go about diagnosing it more accurately prenatally?
Yeah, so if the placenta is not near the scar, let's say you have like a traditional cesarean delivery scar, and it's down low, just above your hairline or what have you, and your uterine scar is about the same location, and your placenta is only at the top of your uterus. There is no biological explanation of why that person has a higher risk of Accreta, like zero, actually. And so I think that the studies have not supported that woman that I just described of having an increased risk. We do see patients who have either a low-lying placenta or a placenta that's implanted over their scar but not over their cervix. And so that patient wouldn't have a previa, but the kind of the mechanism of how it formed in finding that kind of that scar, that avascular area, deeply implanting in the scar, that's kind of the same as a previa. Allison, I agree with you. We need to do a better job of working on markers for patients who don't have previas but have Accreta. And we've looked at that task force that I mentioned earlier, looked at that, and we actually purposely excluded it because there's no good data to support using any marker for that. We would, first of all, it's been very poorly studied. And what we know is that for the patient who has no risk factors, first-time mom, not IVF, we'll say non-smoker for the sake of this discussion, and has a placenta towards the top of her uterus and nowhere near her cervix, and has some markers, some ultrasound markers of PAS, the likelihood of that patient having Accreta is close to zero. And so people have done that study. In the low-risk patient, ultrasound markers actually aren't helpful at all. And so I would argue that the placenta in the patient with multiple cesarean deliveries, but the placenta is nowhere near the prior scars, that patient, those markers probably aren't particularly helpful. That's where a biomarker would be probably helpful. But we're not there yet, unfortunately.
Thank you. We had a couple of questions. Some come in before and one come in during the live, which I'm going to put up. This may be a basic question, but just to kind of reiterate the why behind method of delivery with an Accreta diagnosis.
Yeah, sure.
Could you elaborate on that? Yeah.
Yeah. So most Accretas have a previa. And so that means that the placenta is covering the cervix. and it wouldn't be safe to dilate your cervix if your placenta is covering your cervix because you would bleed. I think in the absence of a previa, then I think it's worth a discussion about how likely the diagnosis of Accreta is real. Again, commenting that there aren't a ton of ultrasound markers for that patient. Sometimes MRI is used in that scenario, but if you have a previa, you should not have a vaginal birth. I feel strongly about that. You will bleed. And if you don't have a previa and you're told you have Accreta, I think just having an honest conversation of how confident do you feel about my Accreta diagnosis to then help kind of determine what the best mode of delivery is. And I think that's probably true for every discussion we have in terms of, hysterectomy planning, whether we're doing other things. And but that's kind of where the mode of delivery comes in. If your institution is only going to offer you hysterectomy for management of your Accreta, and they're really, really confident you have an Accreta, having a vaginal birth and then going to the operating room to do your hysterectomy, in my mind, probably doesn't make a lot of sense. But I've had patients request it, and we've had a conversation about it. And I think that all of this is just kind of what do you value? What can we do to keep you as safe as possible?
Mm-hmm. Well, I think we definitely got a lot of questions about diagnosis. Of course, we're all always eager and curious about that, and delivery experience. And I know that right now you're focused a lot on postpartum experience. And, we've spoken in previous live streams about the impact of PAS on quality of life, of course. So if you would share maybe some of what stands out to you as a provider, like what you would love to see focused on in postpartum care, in the post-care environment for survivors.
Yeah, I think that one is that there's a real, and I think many here would agree that PTSD is real, and I think some of my colleagues have shown that in a scientific way, but just anecdotally, I think even just coming back to the hospital is often jarring for patients, and having a kind of mental health provider, whoever that is, who's dedicated to your patients with PAS and having them available during the pregnancy, but really during the postpartum period, because patients will tell me, I just remember, the blood hitting the floor. I remember that sound, right? And sorry if that's jarring for anyone on the call, but I can't get that out of my head. Every time I turn the water on, I hear that, or the husband will say that, or the partner will say that, or they have to go back to the OR for something else, and years later, and they'll reach out to me and say, I was really nervous because the last time I was in the OR, I was going for my my hysterectomy for Accreta, and this was for a skin tag removal or whatever it was. It doesn't matter, right? And but that kind of triggering experience for them was real. And so I think that the more people can talk about those experiences and not silo them, and be open with your partner and open with your mental health provider if you have it. I also think that, and I don't know, there were some NAF survivors who used to write letters to patients. I don't know if you still do that, but one I remember particularly used to actually connect, they connected on email with my patients. And I remember patients mentioning the same person's name. I'm not going to say it, but same person's name numerous times, be she was amazing. I have no idea where that woman lives actually, but thank you. I don't know who you are, but thank you. And you helped patients. So I think this community helps. I think patients feel alone, right? Yeah. And I've heard Kristen use not her own experiences, but sharing what other people have talked about, when you, just the idea of losing your ability to have future children, even if you never wanted children again in your life, the idea that was taken from you, that is jarring. And womanhood and all these kind of emotions that we have, and so I think having kind of just open conversation is really, really important.
Absolutely. Thank you for bringing up the letter writing project, actually.
I loved it. Loved it.
We've heard so many amazing things about it. And just for folks who are tuning in, we started a campaign in COVID times, actually, of where we had Accreta survivors would write letters and we would mail them to some hospitals and doctors like Dr. Shainker, who signed up to receive them, high volume Accreta centers, and then they could give them out to their patients. It was a really popular program at the beginning of COVID, and then it kind of dwindled out, and we realized as a foundation we didn't have as much visibility into it. So we haven't been promoting it for a little while, but we still think about it, and it has come up from many doctors, not just yourself, having similar stories about how impactful it is. So we have been having conversations behind the scenes of how to bring that back in a really powerful way. So stay tuned, folks, because we will have some announcement on that towards the end of the year. We'd love to bring that back. It was a great thing for both the letter writers and the letter receivers. And again, just strengthened that bond of community and helped decrease that level of isolation, which is so common in women who get this diagnosis they've never heard of before, maybe separated from their family, and just understanding that there's a group of us out here who understand and get it and are here to help support them.
Yeah. Yeah, really, those words were, I mean, we don't routinely admit people, but I think originally they were meant for patients admitted in the hospital. But I don't know, I distributed them to my patients who were home. But I think it really created a community that was really powerful, and so thank you for doing it.
Oh, well, thanks for sharing that. We're great to hear that it made a difference. Jory, do we have some more questions? How are we doing here?
Oh, we've got lots more questions. I want to be respectful also of Dr. Shainker's time, of course, but there's a lot of interest around different methods for diagnosis. So understanding that you've already acknowledged that it's imperfect right now, and we have a lot of room for improvement. There's some questions about for example, transvaginal ultrasound as a method for diagnosis with a suspected risk factor, or, what do you see as most successful and useful and important to have utilized?
Yeah, I think once you have the diagnosis, our personal practice is to stop doing transvaginal ultrasound unless there's another reason to do it, short cervix or something like that. I don't find it helpful. I think once we have a diagnosis of Accreta, well, first, transvaginal ultrasound is recommended to make the diagnosis. That's an international recommendation. It gets you right up next to the cervix and behind the bladder. And so I know they're uncomfortable, but they really are quite helpful. Sometimes they're helpful in understanding kind of how broad how wide the Accreta is, and are they getting into structures on the sides of the pelvis? They're not that helpful there. And I actually think that most of us probably prepare similarly for Accreta, whether we think it's bad or not so bad. And so, really deep or not so deep. And so I don't find that particularly helpful. And I know that they're uncomfortable. So our practice is once we have a diagnosis, we don't do them again unless there's another indication. I think if your doc needs a transvaginal ultrasound and there's a reason for it, you should probably let them do it, because they're just trying to get as much information as possible. I think it's reasonable to ask why. Like I get asked why all the time, and I'm happy to answer those questions. But if we already have a diagnosis and we're not worried about something else, then I think it's oftentimes can be deferred. I think the one caveat to that is if you're really concerned that the bladder is involved, which we see in Accreta, transvaginal ultrasound is probably the best way to look at that. But again, I think there's a fair bit of false positive there, meaning we say that there's bladder involvement, but it's probably just very, very thin along the scar tissue. And so it's not perfect. And even the ones, if we kind of put a camera in the bladder before who we thought maybe there was Accreta, and oftentimes there's not, and vice versa. So again, I think once you have the diagnosis, in my opinion, it's not 100% necessary, but if there's a reason why they're doing it and it seems rational, I personally would just let your doc do it.
Someone else had asked about having had 2 Accretas. So the second one they looked for with color Doppler, but still missed. Any research on better methods of detecting? I don't know if you want to elaborate on that.
Yeah, so there are some new ultrasound probes that are being investigated in ultrasound settings, looking at like micro vessels. It's in its infancy, particularly for Accreta diagnosis. Maybe MRI would be helpful in certain scenarios. I think you have to remember that ultrasound is only as good as the person doing the ultrasound and the person interpreting the ultrasound. And so it's a great tool. And in fact, I think in the right setting, you should diagnose about 90% of Accretas. That's what the research studies say. It's about 88 to 90%. And so that's not what we're seeing in reality, just to be clear. But that in the research study, like if we follow the protocols, that we should get that number. And so if for whatever reason Accreta's been missed twice on someone, maybe going to another modality, another tool might be helpful.
Or second opinions too. We've got a great article collaboration with PAS Squared on how this can be an uncertain diagnosis, seeking out second opinions, particularly at places of high volume of Accreta, can be very valuable as well.
Yeah, I totally agree with that. I mean, I think that, we have a large network in Eastern Massachusetts, represent 20+% of all deliveries in the state of Massachusetts, and they all get funneled into one site. That's 7 or 8 hospitals that for patients who there's concern for Accreta, they all get funneled into our center. And so I think I totally agree with you, Kristen. I think there's a role for specialized diagnosis here because it's so rare that most MFMs don't see this very often. And so I think having, again, the tool is only as good as the person using it and the person looking at the result. So second opinions are strong. And I will tell you, patients come to me for second opinion. I always offer them a third opinion. I always say, listen, this is how I manage this. This is what I think is going on. If you want another opinion, this is where I would go. And I even give them a name. I give them their number. And my hunch is that most people probably don't take me up. I'm already the second opinion, but I have definitely had people call me and be like, hey, I'm seeing a patient of yours. And I make the phone call, the next week, hey, I saw a patient of yours. And, it's a small community. And I also think that if the community is close enough that I would utilize PAS Squared and NAF, that if you're in an area where you feel like you aren't getting the counseling that you think you need, reach out to PAS Squared or NAF, and we can probably connect you to the right, at least regionally, the right area to get an opinion.
So we had so many technical questions about diagnostics and modes of it. Yeah, our audience is very, very attuned to the ins and outs of Accreta specifics. So that's a good lead up to one of the final questions that I'd like to ask you, Dr. Shainker. What are you most excited about in upcoming advances in either diagnosing or treating or just the Accreta provider landscape?
Yeah, so I think one is that we are going to see a shift in paradigm of management. I think in Europe, many patients are not having a hysterectomy. Now, this is a whole nother discussion, but I think for the right person in the right setting, that is a very safe method. Comes with risk, but so does hysterectomy, right? So you're just balancing risk. I do fear that, and I've written an op-ed about this and got a rebuttal by the authors who wrote the big study out of Europe, that the US isn't quite ready for routine conservative management. And I say that because I have patients travel really far to come see me and have me manage their care. If I send them back to their community with a placenta inside them, delivered placenta inside them, I'm not assured that their community have the resources to continue caring for her. And so, the one big study that everyone quotes, which was called Accreta, which is out of France, there's national healthcare, and there are regional healthcare centers that have the ability to manage severe complications routinely if they were to happen. And that was about 20 to 30% of the time. That's not the way the US healthcare system works. And particularly if you look at kind of these obstetric deserts that are happening in the middle of our country right now and in the South, I have real fear that, yes, someone may get to a center that does this, or go to a place that maybe doesn't do it that often, but offers a patient conservative management, and she does great. She avoids a hysterectomy, but then has a complication. And then I think we're actually introducing maybe more harm than good. That's my pause there. I think so that's exciting, but again, with an asterisk. I think the other really exciting thing is biomarker work. Now, again, I'm doing the work, so like I'm a little bit biased there, or a lot biased. But I think that there's precedent for us to do it. Like the preeclampsia biomarker just came out in this past year, and I don't think people are using it clinically yet, but at least it shows like there's an ability to find a signal in a pregnant woman to identify a placental disease, and so Accreta should be the same. And so I think that that's exciting to me. That potentially we're going to kind of really improve diagnosis and ruling out patients with Accreta. And again, I think as I said, like it's not the papers that really motivate us; it's the ability to improve care. So that will really improve care and save people some undue burden. So I think that I hope to see that come to fruition, in my lifetime. That would be exciting.
We're very excited about those things as well. And actually, I'd like to put in a little plug. We do have another Accreta Expert Series event from last year that we did with Dr. Zuckerwise, specifically on conservative management, because it is such a complex topic where she went through many things. If anyone's watching this and wants to learn more, definitely recommend watching that video.
Yeah, and I will say she presents that. She's a friend of mine. She presents that data really, really in a very fabulous way. I will say she wrote the op-ed with me, so agrees that agrees that it's not for everyone, right? But it is for many people.
And so as a closing question, I'd love to hear your thoughts on what we as an advocacy foundation and as well as the Placenta Accreta community can do as a community to help improve Accreta care, treatment, and getting the word out.
Yeah, I mean, I think that, you have been NAF and this community have been very gracious and giving to me and my research team. And so again, I think that is invaluable. I think that there are other people who have really great research ideas. And again, it's a relatively rare diagnosis. So, this community is incredibly important in understanding that experience. We can't get that information without you, right? I have 400 plus patients 400 plus survivors who answered that survey. That data is just so unique. And the engagement that, again, I think NAF, kudos to you guys for doing this, but the engagement has really just been amazing. So I think the more you can share your experiences and participate in research, I think if somehow we can improve the engagement for people before delivery, that would be really helpful because we have a lot of data against Ireland, Utah, us. We have a fair bit of data on the postpartum experience, and we're getting more of that. Again, I think Dr. Donovan's study will look at what happens longitudinally during the pregnancy and then postpartum, but kind of doing that even earlier than the third trimester and looking, from the time of diagnosis. And, we have resources to kind of engage the community. And so once there's kind of community engagement to answer those questions, we would love to continue partnering. So I think you're doing what you can be doing and spread the word, prevent the unnecessary cesarean delivery, the PIN, prevent Accreta. Yeah, I think using your experiences to improve the next person's experience is probably the most valuable thing you can do.
Awesome. So you all heard it first. That's the closing call to action here is participate in our studies, our collaborations, make this research possible. It makes such a difference for future moms and for just the trajectory of care improvements as well. So we're going to have a little call to action webpage with some links on there. And I also want to say too, let us know what you think about this session. So we've got a link there for some feedback. If you want to send us some love letters to Dr. Shainker about how much you enjoyed today, please do so. We'll get those to him. And then we will have a link where you can sign up to be alerted once the pregnancy study is live, which should be very soon. And then also for moms who've already delivered, we have a story bank that we would love to add you to. So please share your story with us, get on our group, because then we can contact you when we get requests for media or requests for some of the other studies that we've done in the past that Dr. Shainker shared with us as well. And then lastly, our call to action is to help support Accreta Awareness Month. This is the time to give back, show your appreciation for the foundation, the Facebook support groups, and all the amazing work that's being done for patient advocacy, including bringing incredible events like this one to you. And I just wanted to say a big thank you, Dr. Shainker, for coming and spending time with us today to go through all of this and answer so many questions.
Oh, my pleasure. Thank you so much. Happy to come back and talk about the history of Accreta. That would be fun with you, Kristen.
I know. Let's do it. We'll do
yeah,
it.
let's do it.
That was a great session at SMFM last year. And it's just wonderful. I feel so optimistic about the future of Accreta care, not just with the scientific advancements that we've seen, but also just this amazing placenta Accreta provider and researcher community. There are so many incredible folks like yourself who are just dedicating their life's work to making advancements. And it is just so meaningful to us, the community, that you're doing this, that you're bringing the information to us. So thank you so much for everything that you're doing.
Thank you. Thank you. Thank you.
Thanks everyone for joining us. I thought as a last bit, I would just let you know that you did get a note in advance from a former patient, Casey Lucas, who said she just wanted to thank you from the bottom of her heart for not only delivering their miracle baby, but saving her life last year, just a little over about 13 months ago, that she's forever grateful. So thank you for making a difference in her life and so many others. And thanks to all of you for joining us today. Please stay connected to the National Accreta Foundation so we can keep you connected to information like this as well as other resources. And we'll talk to you next time.
Bye, guys. Thank you.
Thanks.